time patients.
हाँ.
ECMO.
It's okay.
हाँ. So,
Same patient has gone through a lot of many things. Lately it has happened that he had a clot in the pump and he had a GI bleed. For that heparin was stopped. There was a clot in the pump. They had to change the circuit. After that, because the acidity was on lower side, they kept given a heparin and tried to get the acidity up. Acidity has gone to 190. He bled in the chest, and had a hemothorax, and then finally they put a drain. Drain is it has come. Daily drain is around 100 to 150 ml every day. It's a hemorrhagic fluid still. Acidic column is moving well, and heparin was stopped transiently, and then it was targeted to have a lower acidity because there's a acidity is continuously losing. Okay, so the parameters looks to be stable. After putting an acid, the saturation is improved, the hemodynamic stability has come down. Noradrenaline is almost again come down to a 0.01 mics per kg. So in that way is achieved stability after this. Okay. Now it's over to you. You come on the duty and you have to manage this patient.
sir, why the 100% FiO2?
No, it was made at that time. Now it is only 30% FiO2.
And the same ventilator settings.
No, I'll just, it is the rest ventilator settings only.
Okay.
Okay. So we will divide our team. 2 people will look at the ventilator, 2 people will look at the patient, and 2 people will look at the circuit of the patient. So if there are any positive findings, just report them.
Okay. So as of now, the patient is on rest ventilator settings.
Patient is normal,
FiO2 of
delta is normal.
30%.
And on 3700
No, the
RPM,
cleared,
3 liter
cleared.
flow is normal, I think.
So there is some blood
Color
in
of the
the
circuit is
Yes.
bag though.
So ventilatory settings are normal. What about the circuit?
Circuit looks normal.
Okay.
Pressures are normal.
Connection.
What is the color of the
there?
cannula? Is there any kinking, bleeding from the site?
Nothing is there.
Okay.
No, Marina.
No kink.
No melina, no bleeding from any.
And obvious
Yeah.
color change and saturation is maintained.
Yeah. So vitals are also looking fine for this patient. Patient is on minimal
With
NORAD support.
oxygenator and pump.
Sweep flow.
Okay. So only positive finding that we see here is patient is having hematuria,
Yes.
right?
Yes.
Yes, sir. So, sir, I would like to know the reports of the patient. Can I know the patient's ABG?
Patient AVG's pH is around 7.41, POT is around 55, PCOD is around 38, bicarb is around 20.
Okay. Electrolytes and ACT?
Electrolytes potassium around 3.9, sodium is 140, and ACT is around 150.
Saturation is going down.
150. Okay. Saturation of the patient.
And BP is also going
I think
down.
we'll accept 89% saturation at this point for this patient.
Yes. It's sulfur.
Is borderline hypotensive though. I mean,
Yes, BP is also.
CVP is on the higher
patient
side.
is having minimal. Sir, what is the urine output of the patient in last hour?
Around 75 ml per hour.
75 ml.
the
Today
trend
is
has been same
creatinine.
And
Creatinine.
Yeah, it remains almost the same trend.
sir, creatinine?
Creatinine is 1.8.
So a little bit on a higher side.
It remains in the range of 1.6 to 2.
Okay. Sir, last echo findings and chest X-ray findings, if there are any.
The echo finding is the pH has come down to 50-55. Right heart functioning is well. TAPSI was around 12, which was gone down, but now it is around 18 to 20. And EF is always remain normal, around 50%.
So that is also pretty normal. Okay, patient is still desaturation. Can you just check the central oxygen supply if there is any disconnection?
Is desaturated, so I'll go
Yes,
up on the
please,
ventilator
please,
settings.
yes.
So I
Please
will
increase
try
the
to
FiO2.
I'm
FiO2
increasing the
to
sweep
the
gas
ventilator.
flow.
A and P3 is low.
And rate will be
Yes, please increase the sweep gas flow.
So delta
Yeah.
P is increasing.
no, 60,
So
70
it
is
is,
normal.
but it is
63.
quite acceptable.
60 is normal. Sweep.
Yeah, patient is still desaturating. Saturation
Have
is
increased the
around
sweep
83,
gas flow?
84.
Ah,
Yeah,
yes,
increase the
yes,
sweep gas flow. See if there is any blender malfunction, if it's there, if there is any disconnection, kinking
Central
of the tube.
connections.
Central connection, kindly check for it.
Is blender connected?
Yeah, blender is connected.
Temperature of the patient.
Yes, sir. Sir, can I know the temperature of the patient?
37.
Okay.
I liked it.
Okay, so
Now everybody is asking temperature.
we we have gone up on
Delta ठीक है यार.
the ventilatory support. FiO2 is maximum. Sweep gas flow also we have
Great,
increased. Still patient
Still
is
saturation.
having desaturation.
Going down.
Can you check for any clots in the circuit, please? Sir, can I know pre and post membrane ABG of this patient?
Okay. Pre-membrane AVG, pH is 7.41, PO2 is around 39, PCO2 is around 40, bicarb is around 20. Post-oxygenator ABG, pH is around 7.41, PO2 is around 180, PCO2 is around 42.
PCO2 around 40.
So
I'm
is there any
suspecting
change
that,
after changing the ventilator settings also?
No.
No change.
Sir, can I know the hemoglobin of the patient?
Hemoglobin is 9.4.
9.4 and step.
Yeah.
Free
The delta pressures are going up. I am suspecting that there is some dysfunction in the membrane oxygenator of the patient. So I will need one person to take care of the patient and get a crash card ready.
Yes.
I would like somebody to increase the FiO2 to maximum, increase the sweep gas flow for this patient. I will require 2 people who are going to, so basically the plan is that we are going to change the oxygenator for this patient.
Yes.
I will need 1 person on the venous end, 1 person on the arterial end, and 1
to
person,
prime the pump. Prime the
yes,
oxygenator.
and 1 person to prime the new
Circuit.
circuit that we are going to
So
put,
we are going
please.
to
With
prime the
connector.
circuit.
So clamps and cart, I'm keeping it ready. I'm keeping the next oxygenator also
I think
ready.
you have to,
No, no.
Yes.
okay, sir. Yes, sir. And then we will go.
I'll prepare
Okay.
the oxygenator.
Yeah, you'll prepare the, you'll be on the
I am
arterial
also
end.
coming with the patient.
Okay.
Yes, so before going to that, I would just like to clamp both the ends, and I would like to see how much time the patient is giving. But I think we are already on
Already
80%
on the-
saturation, so
yes,
we don't
yes,
have that
good.
much of time.
Yes.
Okay, so you've prepared the oxygenator. 2 people I will need, 1 person on the arterial end, 1 person on the venous end. Can you?
Connection.
Yes.
We will require 6 clamps. So here we will require 4 clamps, 2 clamps
No,
on
no,
the new
you change the circuit
oxygenator.
there only.
Okay, I'll just show it here then.
Well,
Where we are
just you have to put a clamp. Once you put a clamp there, put a clamp here.
Okay. Okay.
You go there and
Okay, you get the
ask them
other
to cut
2
with
clamps.
the
We'll just show it
connector.
to.
No, we have to put the clamps first
Okay.
properly.
So
On the arterial side, I'll put the plastic
Yeah,
clamps.
this is
On
the
the
arterial
venous end, I'll put the metal ones.
This is the arterial line. This is the. No,
Uh,
no, no.
We have to
This is
decide
the
where we are
arterial
going
line.
to
This is the
cut.
It
this
will
is
go
yes.
from
This is the
from
arterial line.
here
Yeah,
to
here
that
and
is
here.
going to
Yes.
Here we are going to clamp, and then here we are going to
Okay.
clamp. These are the 2 places.
So
where
can we
are going
mark
to
it with a
clamp.
marker? Yeah. So
What?
Yeah.
do we have a marker?
Okay.
So first we are supposed to clamp
Marker.
the arterial
The
end, and
arterial
then we are
Yeah,
supposed
thank
to
you.
clamp the venous end. So
This is
the
arterial.
arterial end.
Okay, I'm clamping.
Clamping
We will
the
be needing.
arterial.
We'll be
We are
needing.
ready for
No,
the.
no, we are just showing it here, and then we will go there,
Oh.
and we will go.
Okay.
Yeah, we'll just show it
Okay,
with 1 clamp here. So first arterial, and then
Then-
the venous end.
Okay, I'm clamping.
Okay.
What? Clamp.
Yes.
Okay.
Okay. Let's go there.
तो निकाल के लाए ना
So you'll be on the arterial
Hold
end.
it. Hold it. Hold it. I'll hold it.
You have prepared
Yes.
patient is
So
having
you see
hematuria. But
yeah,
BP
dark color
was
urine.
stable.
Yes.
Hemoglobin was stable. So
then you see hypoxia, and then you see increased delta
increased in
pressure.
delta
P,
pressure.
yes.
Okay. Okay. So what prompted you to think that it is an oxygenator failure only?
Because we checked for the clots, sir, there was no clots in the circuit, and there were no clots in the pump also. Second thing,
Delta
Okay,
we
what
did
prompted
the-
you?
Hypoxia and raised delta P, rising
yeah,
delta P. was
rising
there.
delta P.
That's why we-
Anything else?
Pre-oxygenator and post-oxygenator ABG also we saw, but there was not much of improvement in PO2 in
Okay,
the
okay.
post-oxygenator
Fine.
ABG.
We'll just revise. Can anybody tell me what was the post-oxygenator PO2?
PO2 was 180.
180.
Post-oxygenator PO2 of 180. Okay. How much is you expect a normal post-oxygenator PO2?
250.
More than, 250 above.
250 or above?
Yes.
Yeah. If you see a new oxygenator, the post-oxygenator PO2 should be anywhere between 300 to 500. Okay, it oxygenates the blood at most 8 to 10 times what it was. Okay, so the pre-oxygenated PO2, if anybody can tell me what was the pre-oxygenated PO2?
It was 25.
You
not
said
recollect.
40.
Yeah, I said around 38. Okay, so then you are expecting the post-oxygenated PO2 to be around somewhere in the range of 300 to 400.
Okay.
I heard somebody pointed out immediately when the delta pressure is high, okay, and it can be oxygenator failure, which you denied. Am I right?
Sir, initially when we came at that time also the delta pressures were around 60 and
No.
Initially it
It
was
went
around
up to
20 to 30,
70 at
But
that time. I
delta
think
pressure
we
60 to 70 is
decided.
okay.
Yeah.
Yes.
Yeah, and
Actually,
then
we
it
were
went
on
up
that
to
side.
70, then we decided
we
that it
find
is
that this was
oxygenator
rising.
failure.
So
from 30 to
I'm not playing a blame game. I'm
No,
just
sir,
I'm
I
just
think,
evaluating what has happened.
Yes,
Is
sir, I think we just saw the trend of increasing
Yes.
delta
Yes,
P
yes,
We thought
yes.
because
trend
patient
is
is
more
on
important rather
that
Yeah.
same oxygenator
so
for
there's a
quite
trend
some
which is
time.
important.
Yes.
Trend,
Yes,
yes.
sir.
Probably
Exactly.
it was a time where you looked at was a different time.
Yes.
Yes.
They when they came, they looked at the delta pressure and they found that delta pressure was 30, which
Right.
has increased to 60.
60, yes.
Yes.
So for them, the 60 was a
High.
High.
increase,
Yeah.
and they thought of oxygenator failure at that stage.
Yes.
Probably you see
I saw 60
first
first.
as a 60
Yes.
first, and then
Then I
my
saw
staff has to
70.
increase it to 90 so that you realize that it's an oxygenator failure.
Yes, sir, right.
Okay. So again, both of you are right in looking at the trend.
Yes.
Okay. Both of you are right at looking at trend, but it depends on from which end you start with. Okay. If you would ask me what was the delta pressure, if you would ask your previous batch you gave, they were just wondering about delta pressure which was 15.
Yeah, right.
So even when they saw it was 30, before that it was 15. So what I mean to say is, whenever you are looking at these pressures, circuit flow, you have to see that when you take an over, you have to ask that what was when you took an over and what is now when you take an over.
Right.
So that is the importance. So if you would ask me what was the delta pressure before, I would have said 15. So for that 15 to become 60, it was a big jump.
Yes.
Okay. They realized from 30 to 60 and you realized from 60 to 90. So that is, again, all of us agree to one point that it is a trend which is important and not one number. Okay. But you should know what the trend is and how the trend is going. And that's why it is important whenever you are taking an over to find out what is the trend in the ECMO settings. The circuit pressures, the RPM, the flow, everything is very, very important. Okay. Fine. Coming to post-oxygenator failure. The moment you asked me the pre and post-oxygenator failure, I was happy that now you immediately will diagnose it, which eventually you did it. I don't say you delayed too much. You were also quick enough. but you could have become more faster
Yes.
because your thinking process was much higher. Provided I told you 180, I could have told you 100. You could have immediately picked up and diagnosed it. Just to keep you in between dilemma, I just kept it around 180. But anyway, anything above less than 200 of post-oxygenator PO2, that thinks that you might have to change the oxygenator. I don't say only one parameter you should think about. There are multiple parameters to think about. Now, what are the multiple parameters? One of them you said is delta pressure, that is right. One of them is, you said,
Post PO2.
post-oxygenator PO2, 200. Third, you do a torch test
Yes.
and see the clot in the oxygenator. Anything more? One more thing you observed here.
Sir, actually, the first thing which we asked is the pump and oxygenator okay? At the moment he said that delta is changed. I asked you, sir, whether the
There were
oxygenator,
clots.
are we seeing any clots in the oxygenator or something? Or we are supposed to see it and we are supposed to decide.
But did I answer?
You did not answer, sir.
You should have asked me again, isn't it?
Yes, sir.
Okay. So that was the third point. That was a torch test and see a clot in the oxygenator. Okay. Fine. What is the fourth point? Which you observed. In fact, that's the first thing you observed.
Desaturation. Desaturation.
Circuit.
No.
The color of
Color
the
of the
tubing.
circuit.
Yes.
Color
Tubing
of the
color.
circuit.
No, no.
Tubing.
Not color of tubing.
Urine.
What is? Yeah. You asked. When you saw, you said urine is dark
Urine.
colored.
Yeah.
Yeah. So again, that suggests you okay, there can be a
Clot.
hemolysis going on anywhere.
Right.
Okay. So you have all signs which will suggest you have some hemolysis.
Yes.
There's a clot, and that clot is probably more likely to be in the oxygenator.
Yes.
Correct. Yes.
And which is supported by your hypoxia. Okay. And with the history of heparin stoppage
Yes. In the
and
previous case.
targeting lower ACT.
Yes. True.
So now is that clear, the entire scenario?
Yes.
Yes.
So what I mean to say is you have to look everything. What you didn't do is you didn't connected the dots. You picked up everything very fast. I was quite impressed. You picked up, immediately you picked up the urine color, immediately you picked up the increase in delta pressure. But then you could not able to connect it. You planned also, you planned well. So what I'm seeing is the latecomers are becoming more and more smarter. Probably we have to become more smart now. The reason is, you see, you are observing what is happening with the previous batch and you are trying to improvise
Yes.
it.
It's in the back of the mind that
Yes.
there should be oxygenator failure.
Sir,
So, when the Ram said last time, कि you had a good division of work, we saw that every team is coming with a division of work beforehand. In fact, the last team was, he came and just took the torch, so before the scenario starts. So they are all prepared, that we can see easily. And we are happy. Provided this preparedness you carry away with you in your
Your
clinical
ICU.
scenarios also, then we are definitely going to be more happy in that. Not only here, but that. The next time the last time what we had to discuss was, there was a two teams, but there was no interaction and the leader was not doing, was not able to communicate everyone. She tried to communicate things and, try to nullify whatever the deficiencies remain in the last day. So that is again a thing which I appreciate, that you are, even sitting down, you are quite observant that what is going wrong and you try to rectify. You don't commit the same mistakes. Okay, fine. So that's about the thinking process and the diagnosis part. Now coming to the management aspects. Okay. So how did you do as far as management is concerned? clearly you divided the two teams, okay? One looking after change of components and one looking after the patients,
Yes.
okay? What did you do, the patient team?
So clinically, I was monitoring the hemodynamics. So there was a drop in saturation over the time. And there was bradycardia also. So ventilator, it was already switched on to full support ventilator mode. So I didn't go to change anything in that. So when there was a bradycardia and some hypotension, I started on some inotropes. As she said, we kept a bicarb ready at that point of time. When there was heart rate went below 60, started on CPR. Then after the pump connection and everything, when saturation regained, stopped it.
Okay, the two questions to you. One, do you think could you have done something more in managing the patients when they were changing the pump or when they're changing the oxygenator? You increase the ventilator settings. Did you miss any one of the points?
So we increased the sweep
Sweep
gas
gas
flow.
flow.
You increase the sweep gas
Yeah,
also?
we-
Okay,
Yes.
I didn't heard of that.
No,
No, no,
we
we
said
were
yes.
on
we
the
had
same.
Fine, so I'm sorry, I didn't heard of that. So
We
that-
were on the
okay.
ECMO and
Fine.
we clearly.
Yes.
So that's clear of the points. Okay, so you increase the sweep gas flow also. Okay, so I'm happy you listened to me. Okay, second point. Okay. Now, think retrospectively and tell me, was the CPR indicated?
No, sir.
So,
See,
even I was confused whether to do or not. I was in a dilemma whether to go. But as patient was dropping the heart rate, preemptively I did it. I don't know whether
Okay,
it was
I'll rephrase the
required.
question. If this patient would have been in your ICU, would you have started the CPR?
So I would have waited for some time.
Yes. The reason is the heart rate was descent. There was no tachycardia. Okay. Now, why I'm reluctant about CPR? It's a simple procedure. Why I'm emphasizing that?
Sir, it's oxygenator failure only. So if we connect the
No.
oxygenator, heart rate will pick up.
Yeah, that's fine. Okay. What we are discussing is CPR. Okay. Even suppose she has an unindicated CPR, is going to harm?
Yes.
Yes, sir.
Definitely
We don't
some
want
kind
any
of-
might end up with more
Yeah.
thoracic
Bleed
damage
may-
and
Yeah.
structure.
So that, again, see,
Cardiac and thoracic issues both.
yeah, if if you break the ribs, then that's going to be
Yes.
it's going to
Yes,
be more
problem.
trouble. Patient is going to be on heparin and that's okay.
Yes.
Fine. So that was second. That was the patient management part. About the circuit management aspect. Okay. Who has done the change of the circuit?
So we were little haphazard in that because the patient team also got involved in the circuit management. So
Yes.
there was only one person who was looking
She was
after
the
the
only
patient.
one dedicatedly standing
Then-
there,
then-
so I appreciate her.
Sir, then I left it and I came there for support.
But then she didn't left her front.
Yes.
That's the thing which I appreciate.
Yes, sir.
Fine.
Yes, sir.
So who has changed the circuit and what are the difficulties you found it?
We kept one person on arterial and one person on venous end, and then one person was with the saline, and one person has done what do we call primed the new oxygenator circuit that was there. So I think you were on the arterial and venous
Venous.
end. You were doing the saline, and
We are priming
you
the
have
circuit.
primed the. So
Yeah. So now okay. One more thing. Did you went to a change of oxygenator yesterday?
Yes.
Yes.
yes,
Yes.
we did.
Yes.
Yes, sir.
How much time did you take that time?
Yesterday it was 2 minutes 47 seconds.
You were
For
with me
RT.
or?
I was with you on this. one,
Okay,
yes.
fine. So you took 2 minutes and 47 seconds. And now from that, you come down to 76 seconds
Yes.
Yes.
within a day. There's a huge difference in this.
Yes.
So what did this difference, how did you get this difference within a day from 2 minutes 47 seconds? That is almost around 167 seconds to 76 seconds. You just reversed it.
Yes.
Even less than the half times.
So actually,
How did it happen?
It was a practice. Yesterday we did it hands-on. So we got some experience, some muscle memory sort of a thing. And today, as compared to yesterday, it was more organized. Yesterday people were doing their work more
Exactly.
haphazardly.
There was
People
no
were
team
getting
effort at
included
all.
everywhere.
Yes.
Everybody was putting their hands in between when we were connecting the circuits. So today the roles were defined. So nobody was bothering the other person when they were doing their job. And I think they have done it perfectly.
Yeah.
Here all of us
So
knew what we were doing.
Coming to that, the organized work pays you, isn't it?
Yes.
Yes.
So that is what the important aspect is. if you are organized, if the team is known, everybody knows their work, and everybody sticks to their work, the way she remains stick to it, whatever is happening there, she was not bothered, but then she remains stick to it. That's the way it has to be done. So if I have to manage the patient, I'll manage patient only. I will not jump into what is happening. There are enough people there who will manage that. Okay, unless I've been called for.
She
Okay.
had to call.
So
I called for an help.
yeah. So unless I've been called for, then I'll go. Otherwise, then it has to be managed by the person. Okay. So organization makes a lot of difference. If you are getting properly organized, then things makes difference. Okay, fine. Did you find any problems in changing it? There was some air or anything?
There was
There
some
was a
error in the
little bit
arterial
of error.
side.
Okay.
Was some-
Which you ignored.
De-aired.
You did
De-aired
it.
it.
Okay, fine. So that's the second part of it. Okay. We are running short of time, but I'll just like to go to now connecting the chains. Okay, for this patient. And I want to brought up a new issue which is probably related to your scenarios, but not entirely depend on that scenario. If you revise last three scenarios, okay, what was the last third scenario?
ICD?
ICD.
ICD
No,
insertion?
pump failure.
It was a pump failure.
Pump failure, then
Why did the pump fails?
There was
hemothorax.
Yeah.
Why did the pump fail?
Clot in the
Clot.
blood.
Clot.
Clot.
There's a clot. Agreed. But why there's a clot?
Blood transfusion was given.
No.
Heparin was
Inadequate.
stopped.
Heparin was
was
stopped
stopped.
because patient has GI bleed.
bleed.
Okay.
Yes.
So it started with GI bleed. You stopped heparin. Patient had a clot in the pump. What was the next scenario?
Hemothorax and ICD
hemothorax.
insertion.
Hemothorax
ICD insertion.
and ICD insertion. Why did that take place, you feel?
Because we increase the heparin.
You increase the heparin.
Yes.
Okay. So first you stopped heparin, then you increased heparin, and
Then again stopped.
And then at the end of it, to reduce the bleeding, we decrease the heparin.
you
So
stopped and decreased the heparin after that.
Then oxygenator failure.
then oxygenator failure.
That caused the oxygenator failure.
And that was the
Oxygenator.
oxygenator failure. So your scenario, retrospectively,
Starting.
thanks to your previous batch, and their scenario, retrospectively, thanks to the
Yes, sir.
their previous
GI
batch.
bleed, guys.
That's the joke apart. What I mean to say is, this is what you see in a prolonged ECMO. And you are confused.
Yes.
What to do? You try to maintain HCT on lower side. You see clot somewhere. You try to keep a HCT on higher side. There's a bleeding. Okay. And this is what happens usually in a prolonged ECMO. Okay. Why? The reason is when the prolonged ECMO is there, the coagulopathy is going to occur. That's one thing. Second thing, your ACT may not be only reliable things. Remember,
Check for
PTI and
as the number of days increases on ECMO, ACT reliability decreases. And if you continue to believe only on ACT, probably you might keep on getting these kinds of hiccups. Then you have to think about something more advanced than that.
Peg or
Tag or
rotate.
rotem.
So you have to think about APTT. That's one which can easily do it and correlate it. Anti-10A
Okay. Entertaining. For heparin
and
specific.
TAG.
Yes.
So this is not only for you, but for all the three batches, okay,
Yes.
that you have to understand that if you are facing this problem, STT, this is not just a scenario, okay, this is a clinical walk through that what we have seen it, okay. That is what happens when there is a prolonged ECMO. And then that balancing the clot versus bleeding is going to be a big challenge you are going to face, okay. So, and that's why just as the number of days increases on ECMO, just don't rely blindly on ACT. Start correlating ACT and APTT.
Yes.
So at least I don't say do APTT 4 only. You can do it every once in a day also. But then you see how much is the ACT and how much is the APTT. Correlate that and target and believe more about APTT rather than an ACT. That is number one. Okay. If you have a facility of monitoring NT10A, that's the best thing you can do. But again, the cost is going to be issue. So in Indian scenario, I don't know how many of us will able to follow NT10A. Not only considering the cost, but also considering the availability of the test. Okay. TEG or ROTEM, or if you have sonoclot, that is all is required if you have this kind of scenarios. So I don't say do it every day or every twice a day or every once in 3 days. I don't recommend that. But whenever you have these episodes, okay, you should get a TEG done, and then you should be more judicious in transfusing.
Yes.
Okay. Or you judicious in stopping heparin or continuing heparin. But otherwise we'll keep on getting this kind of drugs. Okay. Any questions you have or any questions, delegates? Mamsi, you want to say something? Okay. Yeah. Any questions? No questions? Okay,
Sir,
fine.
I have one question. I mean, it's the, we divided ourselves in 3 teams, and with that, what happened that, I mean, not necessarily in these type of events, we will have a proper communication. So one person was looking after the delta P values and all. One person was communicating. So the message was not, reaching the team leader. So do you think, sir, in these type of situations, these things happen on a regular basis because one person is not able to see and one person had seen it and one person has decided that this is the right treatment, but
Yes,
the other person
that's the role of a team leader comes. The team leader has to believe their
Yes.
team. So if someone is raising the issue, probably she could have discussed more rather than saying, no, that's okay. She could have said, why you are saying it is high? Then they could have come up. It was when we came, we saw it was 30 and now it has become 60.
Yes.
So then you should give us, the team leader's responsibility to give us scope to everyone to come out, listen to everyone and make them statements.
Yes.
Okay.
So our team's lacuna was that we were not communicating properly. Or
You were
maybe we too
communicating, but
haphazard.
it was didn't give a proper chance to convey their ideas, why they are thinking. If someone is raising questions, just don't stop that. Yes, no, you are wrong, or that's not required. Say why. Let us know why they want to. Then probably we are also doing the same thing. We never stopped any of the delegates to stop anything. Whatever, whether you are saying right, wrong, we don't react to it. Whatever you say, we are following. So that the reason is that you want to find out what is the in back of your mind. Why do you are thinking that way?
Yes.
So that is the only thing you need to do it.
Yes.
Thank you.
Sir, you.
Yeah, one point you learned from.
So like he said, I think there has to be a closed loop communication, and you have to dwell on the subject when somebody is raising some query. You have to dwell on it and give it some time to clarify the issues.
Yes, that's most important. Yes.
I think our team division was good. So she commanded very well, and everybody did very good job.
See, that's fine. But what you learned from this scenario? What one point you learned from this scenario? Team dynamics is good. I appreciate it. But then what you learned from this particular scenario? Yeah. So tell me one thing. I just want one thing. What is more important?
Trend of delta
Quick action.
pressure.
Trend of delta pressures, isn't it? Yeah. So think about trend of delta pressure is more important rather than one particular values. Okay, fine.
Always follow a trend rather than a particular value. First thing. Second thing, yes, in prolonged ECMO we have to follow APTT also. We are doing
Yes.
PCS
Don't just
only.
be blind on ACT. You have to go think about APTT also when there is a prolonged ECMO. Fine.
We have to stick to our role assigned to us. I went there, I was supposed to
Don't
be on
leave the patient
side
in
and-
Yes, that's a very good lesson you learned. Very good. Thank you.
Preemptively jumped for CPR. Could have waited for some, take a step back and
Yeah, be judicious of whatever you are doing, okay? You should able to answer. You have to keep that in mind that you have to answer someone after that. Okay, if that is there in your mind, probably you will become more judicious. You will not be reflexively doing. Probably you just reflect. Probably what I feel, I don't know, even I am judiciously thinking, okay, is it that me and Ram is forcing you to do unjustifiable thing because you have fear that, even the same feeling I felt with the last batch and the same feeling I'm feeling, you have fear that now we are going to throw something and then you get more panic. So before that only you start acting. Is it that?
Probably.
Yeah, okay, fine. Yes.
So maybe connect all the dots to come to a proper diagnosis and act promptly.
Yes, good.
And sir, we do have to get an idea about the previous events which might have led to the current condition of the patient.
Yes, so you to see the entire scenario in sequence. Okay, thank you.
Thank
Thank
you.
you. Thank you, sir.